there's extrinsic and intrinsic stain. Exogenous and endogenous stains. It says exogenous can present as extrinsic or intrinsic, and endogenous always presents as intrinsic. So these are your 4 categories, and stains can be 2 categories at a time. Like endogenous is always intrinsic. So, it's 2 categories. And these are things you learned in Miss Meyer's class that are going to come back in this topic. So we have tobacco, chlorhexidine, all these types of stain that are exogenous or endogenous. And we're going to learn what that means. They can be exogenous, becoming extrinsic, becoming intrinsic. So they can be exogenous, being extrinsic and becoming intrinsic. And endogenous are always intrinsic, and then there's a list here. So when you're studying for the quiz, you need to refer to this and be sure you're clear what each of those 4 terms mean. Exogenous, endogenous, extrinsic, intrinsic. All right. So this is just kind of a summary review. So let me share again and go to the PowerPoint. Dental deposits and stains. Oh. All right, try that again. There we go. Okay. So if anytime you can't see something, let me know if it didn't pop up. It looks like everything's sharing fine today. So disease-producing microorganisms attach to intraoral surfaces and colonize. The potential effect is dental caries and inflammatory changes in the periodontium that can lead to destruction of tissue and loss of attachment, including bone. Doesn't say that, I'm adding that. During the clinical exam of dentin and soft tissues, the hard and soft deposits that accumulate must be assessed. So that's part of it. The acquired pellicle, materia alba, food debris, dental biofilm is the bacterial plaque. Hard deposits are your dental calculus. That is the dental biofilm, the bacterial plaque that has been on their tooth long enough to and left undisturbed to harden. So what is acquired pellicle? That was first step here, remember? Acquired pellicle. Let me just scroll up. It is a thin, translucent, acellular, it's bacteria-free, unstructured, non-mineralized layer. It's thin. So it's important for you to know everybody has acquired pellicle, and they have in its most virgin form, it has no bacteria. By nature, the term acquired pellicle means bacteria-free. Okay, so you need to understand that and know that. Acquired pellicle is bacteria-free. It's thin, it's translucent. But if we go down, we see it is susceptible to extrinsic staining. It's a layer on the tooth that can absorb stains like my tea and coffees. The thickness varies, but it usually becomes greater near the gingival margin. Forms within minutes following removal with an abrasive. In other words, after you polish and patients feel that slick feel on their teeth, even if they have really good home care, no true plaque you had to remove supragingivally or interproximally, they were flossing well, even those patients are going to have that slick feel. That's because you remove the acquired pellicle that was this thin, translucent layer on their teeth. But it will rebuild within a few minutes after you've polished. And that's what they're talking about with an abrasive. The significance of the acquired pellicle. It's composed of glycoproteins, which is supragingival saliva, and subgingival sulcus fluid, right? Crevicular fluid. It keeps the surface moist. It's a protective barrier against acids, and it may aid in reducing dental caries. The nidus for bacteria aids adherence of microorganisms. It's the mode by which bacteria attaches to the tooth. So it's bacteria free, it's acellular, but bacteria will attach to this coating. And it's a mode of calculus attachment. So there is a surface pellicle that can be unstained, and you can have a surface pellicle that is stained, because remember, stain does not mean bacteria. Stain is just stain. Tea, coffee, smoking, whatever. But usually if a patient is missing an area significant enough to allow things they've eaten or drank or put in their mouth to sit on the tooth long enough to adhere to the acquired pellicle, they'll probably also have bacteria there because they're missing it, right? There is a subsurface pellicle, which is embedded in any demineralized area of the enamel. That's that pitted enamel we talked about. The demineralization areas we talked about can be around orthobands, that have been on for a long time, especially molars or molar areas of buckles of teeth where the cheek holds the plaque. So that's the subsurface pellicle. It's embedded in the demineralized areas. So if we disclose, the tooth does not remain white and only the plaque turns pink, right? All the teeth turn this pale, like haze of pink. That's the acquired pellicle holding the disclosing. And the thicker, darker staining is the dental biofilm, the plaque. It may be more easily viewed with a naked eye when it becomes stained, or if it is embedded in demineralized areas of the tooth. Must be removed by use of abrasive agent, cannot be removed by rinsing. So this is still the acquired pellicle. But this is showing you that it has the dental biofilm, right? Okay, so materia alba, loosely adherent mass of oral debris and bacteria that lies over the plaque. So when you are filling out your oral exam of the patient, one of the sections is dental deposits, and it'll ask, is there plaque? Is there dental biofilm? Or not dental biofilm, sorry. Is there plaque? Is there materia alba? And is there, supracalculus? Is there subcalculus? So materia alba is a loosely adherent mass of oral debris and bacteria that lies over the plaque. So this would be a place where there would be significant materia alba is if a patient has a slight diastema, especially between molars or posterior teeth. And when they bite like into especially red meats like steak or something, it wedges in that tooth and they're all constantly trying to pick it out because things wedge up in there, and it's more than just, plaque or the food you chew kind of sitting on the surface. It's a layer of food, debris, and plaque that's in an area that it's allowed to build. This also happens, if a patient's not brushing an area at all, they'll get a materia alba. It's just kind of loose, thick mass of debris. It can form over plaque. It's an incidental accumulation where plaque removal is neglected. There are living and dead bacteria in it. desquamated epithelial cells, disintegrated leukocytes, and salivary proteins and food debris. Get it back up here. Okay. So clinical characteristics. Oops, go back to this way. It's clearly visible. It's not hard to see. You don't need disclosing to see it. It's a white or grayish mass, loosely adherent. You go around with your Explorer, you're picking it right off. It's unstructured, non-mineralized, bulky, has a mealy, resembles cottage cheese if it's a cervical area of neglect that has built up. Why is it significant? Soft deposit over pellicle and plaque contributes to gingival inflammation. So this will be a good example of not a food impaction, materia alba, but the patient's not brushing at all or not brushing, barely or whatever. And this is just bulky buildup of debris in the mouth. And tooth demineralization and caries are frequently seen under materia alba. This would be that 12-year-old patient, 14-year-old patient, they have their 12-year molars, they're not getting back to that last molar, slowing down, brushing well, and when they're adults, you'll see the demineralization effect of where that materia alba was sitting and demineralizing because the cheek holds it to the tooth, and it's a common site where you can see. Doesn't always have to be bacteria alba. It can be plaque, a little plaque layer back there that the patient doesn't know how to get to or doesn't take the time to get to as a child. And they'll always have this little white scarring where they had demineralization. Now, if it's not through the enamel where it's a caries, remember it can fix itself. So method of detection, visual. Can be removed with vigorous rinsing and water irrigation and proper home care or periodontal debridement. So it's easily removed. If you can remove something by vigorously swishing, that's pretty darn easy to remove because there's very few things in the mouth that you can remove. Sorry, I'm setting my timer so I don't talk away because I can. There we go, start. So if something can be vigorously removed with rinsing, it's not adhered to the tooth. It's loosely attached, but it can cause gum inflammation and demineralization. So this is what I was talking about with food impactions, the food debris. So this is not materia alba, but you would put it in the materia alba category and then further define it if it's an impaction site, because this is also loose particles, but this is a food remaining in the oral cavity. It's cellular. In other words, there's bacteria that grows in it. Food retention following eating. Unstructured, loosely attached, non-mineralized. More definitions of food debris, you can read that. This is the biofilm, which is dental plaque. Okay, so you need to know the term biofilm. It can be used interchangeably with dental plaque. We're so used to hearing the word plaque as we grow up, and even in our professional terms and discussions, we'll say plaque because we all know what we're talking about. But you need to understand that the word biofilm could be used, and you need to, in your mind, be able to say, oh, that's plaque, right? Just like when you learn another language. When I learned my Spanish, I know hola is hello, biofilm is plaque, right? So you need to understand what that term is. That's one you should know. What is dental biofilm or plaque? It's a complex microbial community, organized masses of microorganisms, including mycoplasms, yeast, protozoa, and viruses, held together by a gel-like intermicrobial matrix. It is cellular. In other words, there's bacteria growing in it. It's the cause of dental caries and periodontal disease. So plaque is our, we should be the experts on plaque. So expect to know what plaque or biofilm is. You need to know how it forms. There's always a pellicle, right? Within minutes of its removal, it reforms. The acquired pellicle is acellular. And then the biofilm attaches to the pellicle. How much biofilm is according to how well the patient takes care of their teeth by brushing and flossing and seeing their dentist regularly, their hygienist regularly. These microorganisms then that have attached themselves then multiply and colonize. So the longer it sits there, the more organized and the more they reproduce, like little, billions of bunnies reproducing, and they organize. So think of, your biofilm as creating, they're like the masons of, the super duty, I can't think what I want to say, like apartment complex builders. They stack on top of each other. They build side by side. They build very complex colonies that allows for more biofilm to grow and mature. Composition differs in individuals and among different tooth surfaces. Changes occur with age of the biofilm. So longer it sits there, it's going to become something different. Still biofilm, but it will change the longer it sits on the tooth. 80% of it is water, which is your salivary components and your gingival sulcus fluids. And what is that? That is your acquired pellicle, right? But 20% is the organic and inorganic solids. The microorganisms make up 70 to 80% of the solid matter. So 20% of the biofilm is these organic and inorganic solids, and the solids are 80% microorganisms, right? Bacteria. And like we saw in the slide before, protozoa, yeast, all kinds of stuff. The population density increases with age. They're not talking about the age of the person, they're talking about the age of the bacterial layer, the plaque layer, the biofilm. The higher percent of microorganisms in subgingival biofilm than in supragingival. So once you go subgingival and you're looking at biofilm, the percent of microorganisms is higher. That's why you try to keep pockets shallow so that a shallow depth, 2-3 millimeters, can't hold as much microorganisms because it's more disease causing, right? Think big picture here. The more microorganisms, the longer it sits there, the more it builds and becomes more colonized and organized, the more disease causing it is. And if that disease causing potential is even greater, subgingival, our goal is to help patients understand what a healthy sulcus is and how to maintain a healthy sulcus without the deeper pockets, because deeper pockets means more microorganisms, excuse me, I'm slurring, more microorganisms that can cause disease. It's typically soft, right? We can floss plaque away, we can floss our biofilm away, we can brush it away typically. It's organized. It adheres closely to the acquired pellicle. It actually attaches to it, to teeth and calculus. So calculus we're going to learn about in a little bit, but calculus is the condominiums that the plaque lives in. So if you leave calculus, we're going to have some discussion about that, but understand that if there's calculus there, there's even more biofilm. And fixed and removable restorations can have biofilm. It is non-mineralized. because a mineralized biofilm is calculus. That's the hard deposit. Minerals have set in it to be hard. So plaque is non-mineralized. We already said there's supragingival, there's gingival, which covers the external surface of the oral epithelium and attached gingiva. So in other words, there's so much plaque, it's on the gingiva surface. And then there's subgingival. And there's fissures, which is in the pits and fissures of teeth. That's why when our toothbrush bristles can't get in deep occlusal pits and fissures of molars, we can get cavities. This is the clinical significance. You guys can read that. I've kind of alluded to all of those things. It can be translucent, right? That's why we disclose it pink, because the patient doesn't even know the extent of their plaque. They have never seen the extent of it until we turn it pink with our disclosing. Unless they have a broad brown staining from whatever, usually our heavy smokers, cigar smokers, you know, back in the day, pipe smokers, they would have the heavy stain and they could see their biofilm because it was thick stained. If it's very, you know, this translucent invisible first bullet here is patients who do a pretty good job brushing, and that's the daily buildup, and then they brush it back off. The thick, dull, dingy, fur-like, covered with materia alba and debris is areas of patients not brushing. It's plaque, it's organized bacterial layer, but it's thick because it's just building layer upon layer. When you use an Explorer, it feels different than the tooth surface. It might feel rough or slippery or soft or slimy. It just, you can tell once you get your tactile sense, it developed in your fingers, that you're dragging across a plaquey layer a lot of times, especially if it's a little tacky. So here's our disclosed biofilm. This is using the two-tone. The blue shows older plaque. The red shows the newly acquired plaque. So this patient has a lot of older plaque. This is showing the undisclosed surface. You can't really see the extent of the plaque. Like our professional eye is picking up, right, these little shadows and shades here, cervically and interproximally. But the patient's seen them for so long, they just think that's their tooth until we disclose it and discuss, no, this is what you should have been brushing off. And we need to help you get the most, you know, efficient way to use your toothbrush and your floss to get that off. So this is using just the red disclosing. It doesn't show a difference between old plaque and new. Everything just turns pink. That's quite, you know, more than acquired. Pellicle will be pale, but the biofilm, the plaque is pink. It's just another picture of it. Water irrigation removes only the outer layer of loose organisms. Remember we said biofilm colonizes and is organized. So like the new stuff that's coming to visit and see if it's going to attach and hang out, you might be able to remove that with your water irrigators. But complete removal takes the mechanical brushing, the dragging the bristles over the teeth, and flossing, and then our periodontal instrumentation and polishing, of course. Dental calculus. What is calculus? It is the biofilm that has mineralized to become hard, tenacious masses that form. Most of us, if we're prone to it, we'll get it on these bottom front teeth, right? There'll be a little layer there that wants to build up because we have so much saliva down there. Think about it. Your classic spots for bacteria to harden into calculus for your biofilm plaque to mineralize is where you have your salivary ducts. So under the tongue, hits the back of those front teeth and bathes it again and again and again with all the minerals in the saliva so that it will harden there faster. The same thing with the distal of your first maxillary molars, distal buccal of 3, distal buccal of 14. That contact will become mineralized because of Stenson's duct, right? Wharton's duct under the tongue, Stenson's duct on the cheek, providing mineralized components in the saliva, constantly flooding that site. So the biofilm will harden faster there. This is showing you more pictures of dental calculus. This person hasn't seen a brush in a long, long time. And that's what they have, like a blanket. More than a veneer, they have a blanket of calculus. So, formation of calculus. If plaque is left untouched, the mineralization can start to happen within 1 day. For some people, up to 3 days. You know, it's really, it's varies person to person. We're each unique, but some people will mineralize very quickly, and they have to do extra. They might, you know, you might have 2 siblings and one like doesn't do all that much and they don't build up that much. And one is like brushing twice a day, just like they're told, and they build up. It's because they don't have as much time to get it off before it mineralizes. So every technique must be as perfect as it can be because they mineralize fast. And you're going to find that variation in your patients. And you have to be kind to them because some people are trying. They just mineralize so darn fast. You have to help them figure out why their bristles aren't contacting an area. Is it a concavity? Is it a narrow root? You know, what is it? And how can you help them? Supragingival calculus, of course, is above the gum line. Subgingival, of course, is below the gum line. So what are their sources? Where are the minerals coming from? The saliva minerals are mineralizing or hardening the above the gum line plaque into calculus, and the curvicular fluid, the gingival sulcus fluid, and inflammatory exudates are providing the minerals for the below the gingival margin plaque biofilm to turn to calculus. Components of calculus, I will double check again, but I'm 98% positive I'm not going to test you on this. What are the components of your calculus? You just need to know that there's all kinds of elements in there. You would think it wasn't this much. And even, you know, fluorides trapped in it, manganese, iron, silicone, chlorine, copper, like all this stuff are minerals that are provided through your saliva, your curvicular fluid, your, you know, how did it say it? Your inflammatory exudates to harden the biofilm into calculus. Organic compounds, non-vital microorganisms, desquamated epithelial cells, leukocytes, and mucin from saliva. What are the clinical characteristics? Well, it's hard, right? And typically we can see it. If it's thick enough, it'll show up on x-rays, this little lighter blob between the teeth, and that we call it spurs or thorns. What you see here, that's your ideal board patient. If you get a patient with these little thorns below the gum line, interproximal in their teeth, you've hit gold. That's an ideal patient. It's not too hard to get off, but you can see it radiographically. This patient, it's a little harder to get off, right? But you can see it. And you can go through the consistencies, shapes, all of that good stuff. Where there's space for it to fill, it will fill. Your lips and cheeks and everything help to shape it. It's pretty much what that's saying. Kind of the same here. You can read through that. The calculus can have color because it can absorb stain. The color is a result of stains derived from blood pigments within the diseased sulcus pocket. So even the calculus below the gum line can be stained from the blood pigments. So remember way back a couple weeks ago, I said, if you talk to a hygienist and said, I had black calculus today, they would go, oh my, is your hand hurting? Because what that means is the calculus that's typically white, tooth color, beigey color, even under the gum line, has been subgingival so long that it has absorbed blood pigments. And once it does that, I'm not a chemist, a scientist to say, but it becomes very, very dense at that point when it turns black and very attached to the tooth, very hard to get off, usually smoother than your rough, loose, not loose, but rough calculus that's more white. So, you know, the color is a thing for subgingival below the gum line calculus. There's the pocket of the gingival wall shaping it, and it goes more into the shapes. You can read up on all the texture there. Distribution, it can be localized, generalized. You know, it's usually heaviest in the proximals, maybe present with or without supra. So if you had a question on boards that says subgingival calculus always started as supragingival calculus, that would be false. You can have subgingival calculus without supragingival calculus, and subgingival calculus is created because of crevicular fluids, not because the supragingival calculus migrated subgingival. Although it can look like a millimeter down, but not down 4 or 5 millimeters. So what is its significance? Just making sure I wasn't missing something I should have told you. Mineralized calculus deposits are always covered with a layer of biofilm. You know, the rough surface allows for adherence of biofilm, which perpetuates the inflamed state, plays a role in the development of gingival and periodontal infections. So bacteria, right, the biofilm, the bacterial layer, is constantly putting off excreting acidic, you know, an acidic presence. And according to what it is, what kind of bacteria, what your biofilm is made of, is how acidic it is. Calculus is dead biofilm that's hardened and mineralized. It's dead. It's not excreting anything. In its purest definition, it is not in any way causing the disease, the calculus. But it's not a pure one can happen without the other. If there was already a reason for plaque to be there and harden into calculus, there's going to be new plaque building on it every single minute of the day. So some of it mineralizes and then new biofilm adheres to it. It's the reason the calculus is there, because there was biofilm in the beginning and then it hardened. So you need to remove the calculus in order to keep the area slick enough for the patient to maintain a reduction in biofilm that will help them be healthy. Hope I didn't throw too many words in that definition. But calculus is not creating the acidic irritation to the gums and the breakdown of the teeth for caries. It is holding the condominiums that the biofilm, it's the rough surface, like if you think of the, you know, the ocean and the coral reef, all of the living organisms attached to all that rough coral. Same thing in the mouth. So you can see it sometimes. Air will dry and turn it chalky if you can't see, if you've gotten it all off. When we can use air again liberally, right now we'll be using gauze to dry to help see, because the tooth enamel is shiny and has a sheen to it even when dry, and calculus becomes chalky by its nature of being porous. You can feel it with your Explorer. You can even feel it with a probe if it's rough enough. And we already talked about that. Subgingival calculus. You can look at this patient and anticipate that debris is not just above the gum line, right? You're like, okay, I'm going to have some work to do below the gum line. And your x-rays would confirm that. These are those little spurs I was talking about that build up below the gum line. Methods of removal. The tartar control toothpaste do not have any effect on existing calculus. So anything that says it's anti-calculus has a minimal effect to begin with, but it can, you know, if it's proven to have some effectiveness in your studies and your research, it is not on existing calculus. It's trying to prevent new calculus. The emphasis is to have biologically smooth surface, which is our tooth surface, which are more easily maintained, resulting in a healthy balance in the microbe population, because we need a microbial population, or else we're going to have yeast overgrowth in our mouth. That would not be pleasant. So we need a healthy balance, and you guys should have learned that, or are learning that in Miss Simmons' class. Oops. Okay, so it is 11:28. I will make a note. We stopped at slide 46 because we're going to talk about how you document your deposits to be clear and concise. So let me stop share on that. And you guys have a good day. I'll see you tomorrow with your CR charts that are due. Both of them are due. And in 2 weeks on Tuesday, your philosophy of dental hygiene is due, and your perio chart on the 17th. Okay, I'll hang on here to the end in case anybody has any questions.